Hello and welcome everyone. Today we'll be discussing about cardiogenic shock, its various phenotypes and the management. What is the latest in this? Regarding the definition, cardiogenic shock is a complex syndrome which is defined as a cardiac disorder which results in a tissue hypoperfusion. So basically shock means tissue hypoperfusion. So the cause of this tissue hypoperfusion is some kind of a cardiac disorder. That means directly heart is at fault. It's a state of critical end organ hypoperfusion caused by a primary cardiac failure. So there is a main problem which is lying with the heart. Crucially, the heart cannot generate sufficient output despite adequate preloads. So everything else is okay, the pipelines are okay, enough volume is coming, there is no obstruction, but the heart itself is unable to maintain the flow. So the classic triad is hypotension, which is often present, a low cardiac output state despite adequate preload, and signs of hypoperfusion, that is cold extremities, confusions, low urine output. A small subgroup of cardiogenic shock patients may be normotensive because of the compensatory mechanisms, but then that's a very temporary thing and it should not stop you from making the diagnosis of cardiogenic shock. Regarding the hemodynamic conformation, you need to have a reduced cardiac index, typically less than 2.2 liters, and capillary wedge pressure more than 15. Nowadays, we don't do much of capillary wedge pressure. Regarding the reduced cardiac index, that is the only thing we need to establish to know that the patient isn't having a cardiogenic shock. It has been classified by the shock consensus into various etiologies, that is acute myocardial infarction cardiogenic shock, heart failure, that is decompensated heart failure, primary non-myocardial cardiac cause like arrhythmias, valvular diseases, and post-cardiotomy cardiogenic shock. And there is something called mixed shock as well, where there are other components to this, like there can be a vasodilatory component. Say for example, a patient with pneumonia, with sepsis, with a distributive shock develops a myocardial infarction. So everything is there, so it's kind of a mixed picture. And definitely if you have a mixed shock, it has a higher mortality. So various phenotypes that we have that has been divided over here are the acute myocardial infarction, where you find an acute loss of regional contractility. The LV is not dilated because it has happened suddenly. Rarely you will find a volume overload. Mainly what you look for over here is the ECG changes, if at all they are present, any markers of myocardial damage, and regional wall abnormality. Reperfusion is the most likely method for treating these cases. Next, you can have something called as decompensated heart failure, where you will see that the patient will have a history of gradual loss of contractility. The LV will be dilated over here, and there is considerable volume overload. In these cases, very unlikely that you're going to find any kind of improvement, but then you have to look for causes of this acute decompensation, and if at all find any method to temporarily bridge the patient to probably transplant. Regarding post-cardiac arrest, again various causes can cause cardiac arrest, being MI being the most common. So whatever it is, there is an acute loss of global myocardial contractility. It can be because of various causes, so there may be or may not be LV dilatation. The likelihood of recovery over here is pretty poor. Regarding acute non-ischemic cardiogenic shock, this is basically other causes of heart problem that are leading to shock, that is a valvular disorder or acute loss of contractility. Here the LV is not dilated, neither there is a volume overload, but here the likelihood of recovery again is very less, because these are very difficult conditions to treat when it decompensates, especially suddenly. So again, there are stages to the shock, A, B, C, D and E. This is called SCAI staging. The descriptions are like A is the patient who is at risk of developing a cardiogenic shock. Here you have a good systolic blood pressure and lactate is still less. But because you know that there is a very large MI, you put the patient as a stage A, which means that the patient is potentially risky of developing a cardiogenic shock. So the most common example would be a large myocardial infarction. Or it can be B, which is called pre-shock, where the hemodynamic instability is there, but you don't really find any end organ hypoperfusion. The lactate is still less than 2, but you do find some sort of hemodynamic instability in terms of low blood pressure or tachycardia or some stick like that. Classic shock is when you have both, you have a hypotension as well as end organ hypoperfusion, which here we are measuring by lactate. Or you can have altered sensorium, decreased urine output, cold clammy skins. Next is worsening or refractory, where you need escalated support. That is, just giving a vasopressor is not enough. You are requiring mechanical circulatory support or multiple vasopressors. Or it can be collapse, that is impending cardiovascular collapse, refractory shock, or the lactate is very high where the patient is immediately, if not treated, is going to die. Regarding the early recognition and golden hour, the golden hour is very important because early recognition and initiation therapy, especially in myocardial infarction, is the cornerstone in improving the treatment. The aim is to initiate the therapy within 60 minutes after the first medical contact. We are generalizing the cardiogenic shock over here, though we are mainly focusing on MI over here, because when the situation happens, it's difficult to determine what exactly is the cause. So we try to find the cause which is most likely and which is most amenable to treatment. Dedicated patient pathways should be there, especially for MI patients, so that they are immediately transported. And for this, the initial diagnosis and evaluation should be done within 10 minutes. Get an ECG, get your clinical evaluation, history, troponins, and lactates. Within 30 minutes, the shock team should convene and evaluate the patient. Designated scores must be done, can aid in identifying patients who are at risk of developing the cardiogenic shock. Next is the essential monitoring. You need the basic monitors, the ECG, blood pressure, EBGs, urine output. Mandatory invasive monitoring, get an art line in, get your CBC and urinary catheters. These are just mandatory stuff which must be attached immediately. And imaging, get your point of care echo done and immediately get the severity, etiology and phenotypes diagnosed. This all things should be completed max within 30 minutes. So first is the pre-hospital triage is important. Next, the early diagnosis, everything should be completed in 10 minutes. The shock should be ready in 30 minutes and treatment must be initiated within 60 minutes. The lesser time we take, the more heart we preserve and the more the chances that the patient will go out with a better quality of life. So just saving the life is not important. You need to give them a good quality. So that quality will come only if you are able to get these things done at the right time. Regarding the heterogeneity of the ventricular atrial coupling, so this is one of the important things which is physiologically associated with the heart and its contraction and the subsequent development of cardiogenic shock. The optimal interaction between the cardiac pump and the downstream arterial tree is very, very important. It ensures that you get a good cardiac output and the arterial pressure is sufficient to maintain the organ perfusion. It is defined as the ratio of the arterial elastance to the ventricular elastance, that is EA by the EES. Optimally should be around 1. This can be assessed at the bedside using echo and blood pressure measurements. Regarding the uncoupling can occur due to decrease in the ES, that is ventricular systolic failure, or in alteration of the arterial tree, that is there can be a vasoplegia. The PV loops visualize this coupling and uncoupling. Therapeutic implications are manipulation of the VA uncoupling, that is titrating the vasopressors, heart rate, and we should personalize the cardiogenic shock management, but it obviously requires a clinical validation as of now. This is a theoretical concept, so we'll explain that theoretical concept over here. So this is the figure showing the pressure volume loops. This is of a normal patient. This is the end diastolic pressure volume relationship. This is the end systolic pressure volume relationship. Here you have the volume on the x-axis and the LV pressure on the right axis. In the end systole, the lines are drawn, and this line represents the ventricular compliance, and this the arterial compliance, elastance. So this is what is called as the normal pressure volume curve relationship, where you have the value around 1, which shows that there is a good cardiac function and there is good coupling between the cardiac function and the arterial elastance. So what happens with cardiogenic shock is, as you can see here, the cardiac contractility decreases. So the relationship is changed. As you can see, the slope falls down. Here it was like this, it falls down. So this fall down is the reduction in the ventricular function. So the elastance goes down. So because this has come down, the arterial elastance has to go up. So this is what is called the typical picture in cardiogenic shock. But in mixed kind of a shock, this also can go down. So there is both things going down. Your ventricular elastance is also going down, the arterial elastance is also going down. So this is a more worse kind of a scenario for the patient. So what is macro or microcircular uncoupling? So there is a dissociation in perfusion. The cardiogenic shock resuscitation conventionally optimizes the macro hemodynamics. So we mainly target the systemic blood pressure, the cardiac output. However, the traditional macrocirculatory markers may be insufficient to reflect the adequate perfusion and oxygenation at the microcirculatory level, where actually the shock is taking place. So microcirculatory alterations like endothelial dysfunction, microvascular thrombus or tissue edema have been identified in cardiogenic shock patients even when microcirculatory variables are within therapeutic range. So this is important. Just by achieving a BP target or a cardiac output target, we do not guarantee that the shock is resolved, because these things can be there. So you use an intra-aortic balloon pump which improves the macro hemodynamics but do not necessarily improve the peripheral microcirculation. So regarding the monitoring, bedside parameters like simple clinical tools of skin mottling, capillary refill, they reflect the microcirculatory dysfunction and are associated with impaired outcomes. Advanced like side stream dark field imaging allow direct assessment of the sublingual microcirculation. The DAMASC clinical trial showed that monitoring the sublingual microcirculation significantly influenced treatment changes and did not result in improved microcirculatory or decreased 30-day mortality. So this is how the basic damage occurs. There is a damage to the myocardium resulting in impaired cardiovascular function. So this will cause hypoperfusion, myocardial injury, reperfusion injury, and also inflammation. So you will have inflammatory markers, damage associated proteins, which will go on to affect the other organs. Apart from that, you have the hypoperfusion as well. So there is also an effect on the ATM and CDDP3, which will cause vasodilatation and ionotropy changes. Regarding the molecular heterogeneity, the need for mechanistic signature and finding the subphenotypes of cardiogenic shock is important. The traditional syndromic approach that we have seen till now, different like myocardial infarction related, non-myocardial infarction related, cardiac arrest related, they fail to consider the heterogeneity of the underlying mechanistic signature. As you saw in the last figure, it is quite heterogeneous. It can go anyway and anywhere based on the patient's own personal changes. So cardiogenic shock triggers an inflammatory response which causes vasoplegia and exacerbates the injury. Several sterile tissue damages release the DAMPs and triggers the inflammation. Now you also have biomarker driven subphenotypes like unsupervised machine learning has been applied to integrated biomarkers from different pathophysiological domains in cardiogenic shock patients, and it did find out 4 distinct molecular subphenotypes. The subphenotypes which are independently associated with higher mortality are inflammatory, where the highest concentration of biomarkers of endothelial dysfunction and inflammation were seen. And there is a cardiopathic, where the highest concentration of myocardial injury and fibrosis were seen. So these are the two markers or the subphenotypes where you have a worse outcome. But these are again just in learning phase. We haven't yet learned how to classify these patients into these groups, means in a real time. The potential of precision medicine is definitely there. These subphenotypes provide a new way to classify the cardiogenic shock, supporting the prognostic enrichment and personalizing our interventions. Molecular subphenotyping incorporating actionable circulating markers like we saw ADM, DDP3, they may improve identification of patients who can be benefited with targeted therapies, like therapies that are targeting the inflammation, the endothelial modeling. They can be useful. Regarding the management, mechanical circulatory support is a very important measure, especially right now when we have a lot of technology available. The MCS is often used in acute myocardial infarction due to the high mortality rates. Despite revascularization, its aim is mainly to support the organ perfusion, prevent further organ injury, and promote recovery. Optimal patient selection is crucial as many patients survive without the mechanical circulatory support, but it would only suffer if there is a complication to the mechanical circulation. While others with refractory shock, this can be life supporting. So these are the various devices that we have. Intra-aortic balloon pump, which is a passive device which gives only modest organ perfusion, and it has its own side effects, and it's rarely used nowadays because of the negative trials that we have seen, mainly reserved for mechanical complications of myocardial infarction. You have other devices like the microaxial flow like Impella and ECMO. These devices have better tolerance and they have better effects on the microcirculation. So the outcomes can be better, but they do have their complications and cost associated with them. So they must be evaluated further before we implement them more proficiently in our practice. Regarding studies, you have the IABP Shock 2, which was on the IABP usage. It showed no effect on 30-day mortality. So no routine usage in infarct-related cardiogenic shocks. You have the Danger Shock trial, which had 360 patients, and it is STEMI cardiogenic shock. They evaluated the standard care with mechanical assist devices versus standard care alone. The population was predominantly STEMI with left ventricular failure with moderate lactate around 2.5, excluding comatose patients, that is those with out of hospital cardiac arrests. They observed for a statistically significant reduction in 180-day all-cause mortality. The benefit came with increase in complications and increased bleeding and limb ischemia. So that must be kept in mind. These things have shown improved outcome, but then complications are a serious effect which must be kept in mind before initiating. Regarding the extracorporeal support, VA ECMO versus standard care in AMI patients for revascularization found no significant difference in 30-day or 1-year mortality. Higher rates of limb ischemia and bleeding complications and low use of routine LV venting and unloading were observed. So both have to be kept in mind before you decide on how to use this. Regarding the meta-analysis, overall it did not reduce the 6-month mortality, though restrictions to STEMI cardiogenic shock phenotype with reduced risk of hypoxemic brain injury suggest a mortality reduction with temporary usage of mechanical circulatory devices. So right now, if you look at cardiogenic shock, we know that there is a lot of clinical heterogeneity. Though most of the patients will be acute myocardial infarction, it is not so for all cases. You will have non-AMI cases also. So it can be new de novo heart failure versus acute and chronic heart failure, isolated cardiogenic shock versus a mixed cardiogenic shock. So you can have a left or a right or a biventricular, anything can happen. Scoring we have already seen, but apart from that, you can have lactate, risk modifiers, and metabolomics. As we have already discussed, there are more evaluation in the molecular heterogeneity. We have found out a lot of phenotypes and subphenotypes, which can be make the management more precise and more personal. And of course, we need to keep in mind the uncoupling. It is important to understand the uncoupling of the ventricular function and the arterial function. How to modify it, how to measure it at the bedside, again, something which needs more clinical trials and interventions. So the conclusion is we are moving towards a precision medicine. The cardiogenic shock is complex, highly heterogeneous syndrome extending beyond etiology and microhemodynamics. And it includes the ventricular uncoupling, the microcirculatory dysfunction, and the molecular variants. This must be kept in mind. Previously, we were just thinking on MI and cardiac support. We must understand there is more to cardiogenic shock than just improving the heart function. There is the uncoupling of the ventricular and the arterial function. That must be kept in mind. The microcirculatory parameters must be checked. Just macrocirculatory parameters are not going to be adequate. And apart from that, you have inflammation in the patients. So there is a molecular and biological variation which will vary from patient to patient. It won't be same from patient to patient. So you cannot have a one size fit all theory for all. Patients often present with varied symptoms, as you have already seen. So the conclusion is that we must have a goal for the precision medicine. The precision medicine should aim to enable and tailor the intervention based on the patient's individual genetics, biomarker imaging, and clinical data. It requires going beyond one size fit all model. So the future directions are integration. Future strategies require integrating physiologic data, microcirculatory monitoring, echocardiography, onomics data to apply on precision medicine. Targeting our therapies to various novel targets, especially the microcirculatory, the subphenotypes, and the anti-inflammatories. Rigorous evidence is required to integrate these things into our practice, especially the machine learning and the new drugs. Thank you for your patience.